is Dr. Kathy Falks from the London Family Health Team, and I'm going to talk with you this afternoon on open access, efficiency, and office practice redesign. My husband's an emergency room physician, and he likes to remind me that I need to be direct and concise with the message that I'm teaching. In particular, why bother with all of this? Why are we going to look at open access? Why do we care how efficient we are? And why do we really care about the systems? I broke it down into 3 levels. First of all, looking at it from a patient perspective, looking at it from the provider perspective, and looking at it from the system perspective. When we talk about the patient perspective, we're talking about improved patient outcomes. And I get really excited when I talk about quality improvement because I've been able to realize with standardization of office visits by implementing evidence-based care that the patient benefits in the end. The second is looking at my own practice satisfaction and how much I enjoy practice now as compared to how I did 4 years ago before I got involved with all of this. I am running more on time. I feel like I have more control over my schedule. My allied health professionals that I employ in my office are much happier working up to scope in their practice. And also we see great system benefits. The system in particular, we're looking at fewer unnecessary visits in our office. We're looking at team care and the introduction of a broader team. When I started all of this, I was a fee-for-service physician with a very small office staff. And now we've expanded to be 6 physicians, a nurse practitioner, multiple social workers, dietitian. So you can see that there are many changes that have taken place to allow open access to come in. We look at the financial benefits, and this is where I really get excited because we look at influencing the system in which we work in. Before we start talking about open access, though, we have to stop and we have to do some measurements. And the measurements that we need to do, I know, will be outlined for you in the QUIP lectures that you're attending. In particular, I want to talk about 3 measurements because this is the very basics that you need to do to be able to understand how you can implement open access. To begin with, we're going to define panel size. And for many of you, that just simply means roster. We talk about rosters with the Ontario government now, with whether or not we're a FIG payment scheme, whether or not we're a faux payment scheme, or whether or not we're even salaried. Everything depends upon our roster. Unfortunately, that's not an easy thing to find a number for, and I know that many of the facilitators will teach you different ways to do it, but I'll let you know that what we do is we look at what the government has as a roster, we look at what we have on our computer, and we also look at what we have in our chart racks. So defining that panel size is very, very important. One of the things that often happens is I'll hear from many physicians about open access. One of the arguments about why they can't do it, why it wouldn't work in their practice, is that they have too big of a practice. And I agree with you. If you're not able to look at your panel size, you're not able to reconcile what or whom you're really looking after, then you can't start to do open access. Open access isn't a quick fix for a supply of office visits that is too little for the demand that you want to put in there. So moving on to demand, we want to look at how many patients we have and how many visits those patients will need in our clinic. The demographics of our practice matter. It matters whether I'm practicing in urban London, Ontario, doing house calls and chronic disease, or whether you're practicing in the inner city of Toronto with a smaller practice of homeless patients, for instance. We have to look at revisit rates, and there's scads of literature on revisit rate, but you have to figure out whether you're the type of physician that brings someone back a lot in your practice, or whether you're the type of physician who will dispense treatment and then educate the patient about why perhaps they would need to revisit, and you give them the ability to decide when they need to come back. Revisit rates in general will be anywhere from 3 to 4 per patient in your practice. And I think that when you look at that revisit rate and you see what you're actually doing, then you can decrease the demand on your practice by making some subtle changes in how you actually do medicine. We want to look at the supply, and so you have to look at your own behavior. I always want to be able to do more than I can. I think the day should be 26 hours just for me. And my office staff constantly remind me that I can only see 24 patients in a morning. It's not physically, I'm not physically able to see more than that. So I have to look at my own behavior. I have to look at the velocity that I see patients in, and I have to be prepared to make changes for that. I have to look at whether or not I can hire or whether or not I can expand my team so that I can put more directive work on their shoulders. For instance, now I work with 1.5 nurses in my office for my current roster. We look at visits and we look at enhancements of visits, and I'll talk a little wee bit more about that further on, but I talk about max paxing the visit, meaning that I don't want to keep bringing the patient back and forth. If I'm seeing them for diabetic care and my chronic disease nurse sees them for their diabetic care, there are no changes to be made in their medications or in any of the lifestyle management that they're facilitating for themselves, then my actual signing of a prescription might take me 3 to 5 minutes with the patient. The patient has had great quality of care. It's at a standard that we're happy with, but then they might have a sore knee. So my chronic disease nurse would move on to the next patient, and I'll get a chance to see them for their acute care issue. That way, I'm not creating a specialty clinic. I'm not bringing patients back and forth. I'm not giving them an agenda that is only one problem per visit. So I have to look at how much supply I have in my office, and I have to be creative and progressive to say, how can I increase that supply? So you need to do these standard measurements. You need to take the time to do them. Nobody is going to give you these measurements. You have to sit with your office staff, look at your computer, your EMR, or your chart rack, and come up with a panel size, figure out your demand, and figure out your supply. And only then can you begin to look at efficiency in your office. So if we go back to the beginning and we look at how do we improve patient outcomes, what do I mean by this? Again, we talk about standardization of visits with evidence-based care. And I've always maintained that it's not that physicians don't know about the evidence that's out there, that we don't go to CME and we don't read about it. And there's scads and books of literature that talks about why physicians have been lousy at implementing evidence-based care. One of my big contentions is that we don't have the foundation, we don't have the staff, we don't have the support structures to do it. And so if we look at standardizing patient visits, how were we able to do that in our office? And what programs in particular did we target? With QIP's help, we started with diabetes mellitus, and we advanced on to insulin starts. We then have gone into COPD, asthma, osteoporosis, and you can see the list goes on and on. We went into counseling. We looked at standardizing our smoking cessation programs, our cholesterol, our obesity approach. We then started with case finding and standardized looking for COPD, saying how can we improve our management of COPD by picking up all of the patients that actually have COPD in our practice. And we introduced spirometry, something which is becoming more popular in primary care, but when we started, it was quite unique. Glucose monitoring as well will feed into our diabetic program so that we're not missing our pre-diabetics. Once we had our diabetic program organized, we decided that we needed to begin to move it back and look at patients who had blood sugars between 6 and 7 and target them before they could even become diabetic. For dementia, we looked at trying to pick up patients that had early onset dementia or MCI early on to give families and to give patients help before there was a crisis situation in the office. And that was very simple by putting a MOCA assessment or a mini mental status assessment for everybody over age 65 at a routine physical or visit in the office. So as part of our first journey with QIP, we looked at program development, and we had a very standard model for that. We implemented logic models for each of our programs. We were able to put process maps in place for each visit, and that allowed each allied health professional, including myself, to know what it was that we needed to accomplish at each of our office visits. We developed templates and flow sheets that we put into our EMR. We used Nightingale, and it was very easy to work with the program planners at Nightingale to facilitate the recording of data in a very standardized fashion. We made sure that our allied health professionals, including myself, had the proper education, CME events attended. We looked at outcome measures and process measures and balance measures, and QIP taught me which ones in particular I wanted to measure, were important to measure, and how I could use those to change the programs. We sat down monthly and met for about a half an hour, 45 minutes each month, and reviewed the statistical information that we were able to collect, and that in turn allowed us to make changes to our programs. So at the end of all of this, we said, well, that's wonderful. Are we going to be able to sustain this? We have one program in place, diabetes, to begin with, and is it sustainable? So we learned about how to measure the sustainability and how to ensure that that's happened. When we talk about different measures, we talk about outcome measures. And outcome measures are something that there's a lot of controversy about in the United States right now in managed care. The most recent New England Journal of Medicine talked about outcome measures being used and interchangeable with accountability. And accountability always ties into finances for physicians and care teams. QIP is not about accountability. QIP is about teaching us how to improve the care of our patients. And outcome measures are patient-driven. They have a lot to do with how the patient takes the information and the education that you impart and the support that you give them and translates that into their own health care. You can see here that one of the outcome measures is the hemoglobin A1C. I don't take a lot of responsibility for the hemoglobin A1C measurement. That's my patient's responsibility. When we started QIP and 2.5, 3 years later, you'll see there's not a lot of difference in that hemoglobin A1C. And you can say, well, did it really make a difference? Well, I think it made a difference because of the following slides. Process measures. Process measures are the ones that I think reflect our team effectiveness. And if you want to hold me accountable for these process measures, I'd be happy to have you do that. The examples are seeing all my patients. If I have an active registry and I know who my diabetics are, remember I've done my panel, I know who's in my practice, then I'm going to be able to see all my diabetic patients. I know whether or not I'm going to prescribe an ACE or an ARB to all of these patients if it's recommended. If they're diabetic with an elevated ACR, they need an ACE and an ARB. If they're diabetic and normotensive without an elevation in their ACR, then I'm not going to prescribe an ACE or an ARB. I know I'm going to examine all their feet. I know I'm going to refer them for ophthalmology assessments, and I know that I want to look at whether or not their blood pressure is at target. So when we talk about process measures, this is a process measure. When I started, I was humbled by the data that I collected, and I kept using that term with the facilitator that we had about how I felt very humbled that the data didn't reflect that I was seeing all my diabetic patients. You can see here that about 80% of them were actually being seen on a regular basis. We now make sure that we see 100% of those patients. I know who they are now. I feel much more informed. I feel much more that I have a good idea of what the big picture is for the diabetic patients. We call them in if we need to. If they haven't been seen, we ask them if there are problems as to why they haven't done follow-up or done their blood work. So we're much more attentive to the patient. This, again, is a process measure. We look at diabetic patients on ACEs and ARBs, and as I said, it's not going to be 100% because 100% of patients don't need to be on them. But once I was able to collect the data on the diabetic patients and knew that they needed attention, we were able to schedule and educate and start ACEs and ARBs in a timely fashion. Subsequently, if you start ACEs and ARBs and you're on top of the patients and you're seeing them, then you're going to get much better blood pressure results. And so the blood pressure control, again, is above QIP targets and recommended targets. This just took off. Malcolm Gladwell talks about the tipping point, and I would say that this was the tipping point for us. We got very passionate. Our team, it became a culture in our office that we were doing QI. Very proud of it. We print our statistics. We put them up on a bulletin board. We talk to our patients about them. We'll talk to anybody who comes in the office about them, basically, because it tipped over into areas of our practice that I hadn't anticipated doing so. The acute patient care, our obstetrical program, our well baby program, developmental screening, acne management. I can go on, and I've listed some of the things on this particular slide as to where we went with all of this information. This is colorectal screening. It's a kind of popular topic right now in medicine. We all know there's a government initiative for this. This actually happened before the government initiative. QIP came in and said, you need to stop and look at how you do prevention. You need to do prevention on every visit. You need to think about prevention more often than just annual health exams. And so, again, you with many different process interventions can get your fecal occult blood screening up at target. I just want to stress again, it's the evaluation of your work that's going to lead to improved access, efficiency, and improved outcomes. Our electronic medical record, we could not have done this without because of a feature called Health Maintenance in Nightingale, which reminds me on every one of those visits what that patient needs or what they could benefit from and how I can educate them about improved prevention. It made all visits fair game for prevention, not only our annual health exams. It maximized our office visit. It allowed us to delegate more to our allied health professionals. So it showed me that I don't need to be doing everything in my office, that I can have my nurse work up to scope. My social workers that are working on our team work up to scope. We created registries for every screening test, and for those of you who are very financially orientated, this allowed me to maximize very quickly my preventative screening bonuses. We were able to send out reminders, and one of the things that we've just started to do is to send out electronic reminders to patients. Nightingale has a patient access portal, and it's so very slick to be able to send a reminder out to say you're due for a pap smear, you're due for an immunization. Again, we're back to why bother with all of this. We've talked about the patient outcomes. You can see that the patient, in particular the diabetic program, has allowed us to achieve a higher standard of diabetic care, and that translates into better medical management for our patients. We did a survey of our patients that looked at whether or not they felt that they benefited from the program that we instituted, and it had a high patient satisfaction outcome as well. So what does this do for me, the provider? How do you as a physician benefit from this? You benefit enormously. 4 years ago, I was actually ready to throw the towel in on primary care. And for those of you who know me well, you'll know that it's my passion. It's what I've always wanted to do. So you can tell how frustrated I was with the inefficiencies in the system that I worked in the lack of communication that existed in our silos of care, and the fact that the paper was absolutely burying me. Nothing has given me more satisfaction than when an insurance company says to me, can you send me an entire medical file? And some of my patients I've known for 23 years, I just press a button on the EMR and off the report comes. And it comes off in a very standardized way. It comes off in a way that they can read, and it's very efficient. So with open access, what's it done? I'm running on time in my office. I got here in time to do this talk, and I had to add a little bit of travel time to it. So I was pretty proud of that. I schedule more. I feel more in control of my life rather than always reacting to things. You can imagine the old schedule when your secretary, someone would call in the morning, and she'd just shove people all the way down the side of your day. And by the end of the day, it was 7 o'clock, and your charts were done, and you had to go to the hospital, and hopefully your kids had gotten to wherever they needed to go to, and you had an incredibly understanding spouse who still wanted to stay with you. Now, I actually schedule. I know exactly how many patients I need to see. I need to see 35 patients in my office to manage my roster of 2,100. I know that I need to see with my chronic disease nurse 7 to 8 patients to manage the diabetic registry, the COPD patients, and the asthma patients that come in. So I feel much more in charge of my schedule rather than reactive. That in turn has given me more time to teach, to be part of QUIP, to do more research. I've been able to put out 3 research papers in the past 3 years, unheard of prior to that. And I've had a lot more time with my family. My adult kids can see a big difference in my satisfaction in my practice. So I'm a palliative care physician, and I can't help but put this statement in: professional satisfaction. At the end of someone's life, what do they talk with me about? They talk about having meaning, they talk about purpose, and they talk about value to their life. It's of great value to me to see that I deliver good patient care. So prior to July 2007, I said to you that I had a nurse who was a Walmart greeter. She wasn't working up to scope. I had utter chaos. I have a very controlled model of care. The very nice thing about all of this is when I started open access, I was fee-for-service. And this is doable in fee-for-service. And again, for those of you who are financially motivated, my income went up by $60,000 the first year of open access. In part, some of that would have been the EMR, but the EMR would not have facilitated that alone if I didn't know how to create registries and track preventative screening. So this is doable in fee-for-service. I've since transitioned. I've been 1 whole month in a FO, so I'm not talking about open access to you from a FO or a team model per se. We've reviewed improved patient outcomes. We've reviewed the impact that this has had on me as a physician and on my allied health professionals and the team that I work in. I want to take a minute and talk a little bit about the healthcare system and the benefits to the system. I'm going to start by talking about third next available appointment. If you called my office back in 2007 and you had a sore throat, my receptionist would have told you that it would be 20 days before you could see me. She might have tried to slide you in opposite a physical, and you would have waited in the office for about an hour and a half, but really the next available appointment was 20 days away. With putting in open access, with making the efficiency changes that we have, we've been able to get that down to a half a day. So this morning, patients called my office and they were seen before I left to come here and do this taping. It's made a huge impact on patient satisfaction in our practice. It's reduced the redundancy of visits in our practice. This talks about red zone and value-added time, and it's a concept that looks at how much time do I as a clinician spend with the patient in the office versus how much time they spend waiting in my office. So where is the value in their appointment? And you can see initially that the value is at about 20%. So they waited at 80% of the time to see me for 20% of the time. And now we're up at about 60%. We average about 60%. That's just me. It's not any of the other allied health professionals. And so if we were actually going to look at this because of the amount of directive work that we've done or the amount of delegated work, and I'm not the only primary care provider in my office during one particular visit, it would actually be higher. We've looked, if we add the nurse on top of this that works in our clinic, it's closer to 80%. So patients actually get more value for each visit. This is one of those research projects that I'm talking about that I had the time to do. I worked with Lindsay Billett, who at the time was a fourth-year medical student in my office, and she's now a resident in family practice up in Ottawa. I worked with a colleague, Dr. Catherine Walsh, who has a very similar practice to mine, and we compared and contrasted what happens if you put open access into a practice and compare that to traditional booking. So Dr. Walsh continued doing her traditional booking, and I embarked on a journey with open access. I also, at this point in time, want to point out that with expanding our allied health professionals, I increased my supply, and by increasing my supply, I took on 300 extra patients or added to my roster. Again, if you're financially motivated and you're in a faux billing system, that's huge. So what did it show? This is a slide that reflects what it showed in my office. It showed that the after-hour clinic visits by my patients, calculated per 1,000 patients of my panel size, changed significantly over the course of the study. Open access booking resulted in a 16.8% reduction in after-hour clinic visits. Our weekday after-hour clinic visits were reduced by 10.5%. So patients were being seen in our clinic and not going elsewhere for after-hours care. This improved continuity of care enormously in our practice, and you can imagine that if you have an electronic medical record which is enterprise, meaning connected to all of the physicians providing care after hours, as is starting in our family health team, that the provider has incredible continuity, accurate medication lists when they're seeing you, the patient, after hours. What happened to the emergency room visits? This is where I really get excited, and this is what got my husband's attention, because he's constantly saying to me, there's so much that comes through my door that is primary care. We have huge access problems in the country. What are you family doctors going to do to fix the problem? So I just show him this slide. The non-urgent emergency room visits decreased by 22.7% over the study period, and our weekday non-urgent emergency visits decreased by 26%. So you can imagine how that would translate 26% reduction for each family doctor in the province by implementing open access. This one, I think, is just absolutely telling, and this is why you cannot continue to do traditional booking. In the same time period that was studied, April-September 2008, contrasting April to September 2009, if you look at open access, the red line, my after-hour clinic use, patients that use the after-hour clinic went down significantly. The traditional booking, Dr. Catherine Walsh's booking, went up significantly. This as well, I assimilated 300 additional patients into my practice. So not only am I looking after a higher roster of patients in the practice, but I'm also reducing the amount of after-hour clinic work that the patients are needing. So what's left to do? Sounds perfect, doesn't it? Contingency plans. I still struggle when I go away to find a locum who works at the same velocity that I do, but I take time. I interview, I have contracts with locums, I've introduced them to Nightingale, we do training, we make sure we set up a locum physician in my office to be there when I'm not there, so that when I return I don't have to do an awful lot of working down the backlog. And this has become a kind of dirty term. I noticed in the Canadian Medical Association Journal, just last night in fact, an article on open access from the East Coast, and they said that they were able to put this in without working down their backlog. Hats off to them. I could not have done that. I worked down my backlog by working one Saturday per month for 6 months, and by adding 1 hour to every Wednesday in my clinic. And what that means is it's taking that 20 days of booking time and bringing it back down to the 0.5. So that working down the backlog, combined with increasing the supply in the office and directing or delegating patient care, helped to get that third next available appointment to 0.5. We don't need just contingency plans for physicians. We need contingency plans for everybody in the office, because when one person goes away, whether it's an allied health professional or whether it's my administrative staff, it has an impact, and it impacts access. So you need to develop contingency planning. Seasonal variation is very important. So we do a lot more physicals in the summer and the early fall than we do in the winter. Once our sick season begins, we have fewer physicals, fewer routine appointments booked. So we just take into account the ebbs and flows in volume, and we need to be able to measure that and look at that. One of the things that I struggle with is introduction of more programs. I get excited by adding more programs and by improving or standardizing care. But when we sat and we figured out if we add spirometry to all of our asthmatics, I would need to hire 2 more nurses. So we had to come up with some changes in our program, or look at our program and say, who would we offer this to first and how would we implement it? So again, when you start to add new programs, you need to figure out how your supply is going to be changed and how the demand is going to be changed and how you're going to supply that. I want to share with you this photograph. When I was reading in the summertime in a journal called Pharos, which is put out by the Alpha Omega Alpha Society, there was a slide submitted by Dr. Justin Palmore, and he was asked, the call for slides was to be able to show worthiness to serve the suffering. And so Dr. Palmore submitted this one, and with the comment he said, "I fervently believe that everyone is worthy to serve the suffering. It's not a matter of worth, it's a matter of heart, and it's a matter of passion. And as the picture so candidly portrays, a matter of willingness to progress in a way that best serves the human condition in every aspect." And so I urge all of you to have a willingness to progress, to look at open access, to look at efficiency, and to look at practice office redesign with a very open mind. And I know and I hope that you'll be able to achieve even half of the success that we've been able to do over the past 3 years in our practice. A lot of physicians will ask me, how do I get started? What do I have to do to end up implementing open access? And I think the first thing is to measure. You have to first be able to study and measure and define what it is that you have. You have to know your panel size, you have to know your demand on your practice, and you have to know how much supply you have. And if there's a mismatch between supply and demand, you have to be able to figure out and put in place some effective strategies to match that supply and demand. Open access will not fix a mismatch in supply and demand. You then want to standardize programs, and in order to develop standardized programs, join something like QUIP, get involved, learn how to do that, learn how to implement those guidelines. Once you've done that, you have to be able to go back and measure and see if those implementation of programs has made a difference. And that's where the electronic medical record makes a big, big difference for you. It's able to do your statistical collection, it's able to do your registries and your roster. At the end of that, then I think you need to be able to say, can we spread this? Can we take this from one particular program into our practice as a whole? I'd like to thank you for listening to the journey that we've undertaken in our own family practice, and I wish you all the success in implementing open access, efficiency, and office-based redesign.